So let's go to the third case. Here we have a 49-year-old male presents with a complaint of a grinding habit and ultimately causing a tooth to split. I don't know why, but this patient is concerned with aesthetics, and he prefers to have treatment as quickly as possible. It's a high-profile type executive, and you can see that the first bicuspid has split. And again, our restorative referrals are ready to assist us with any end result that we can achieve with implant placement. So here at the implant placement, you can see obviously extraction, immediate implant placement. The insertion torque we achieved was at 20 Newton centimeters. It did stop, but there was very little resistance felt in the placement, and an ISQ value of 52.
I think it's important that before we actually answer this question, Peter, for a moment, when you look again from a scientific perspective, and when we talk to our colleagues, and I was talking to someone outside before we came in here this morning about what we're talking about today, and this particular clinician said, well, why do I need this device? You know, I mean, I can feel the insertion torque when it goes in. If it works, it works. If it doesn't, it doesn't. Well, you know, that to me is not a great answer. And Dujiti, back in 2010, had a great article where he compared the surgeon's tactile reporting of the insertion torque versus what the ISQ values came up with, and they were different. And so our ability to be able to feel the difference between the high insertion torque and relate that to what truly is the implant stability quotient through the radiofrequency analysis may be two completely different things. So we really do need a more repeatable, scientific, reliable method of being able to record what is happening not only at the moment that implant goes in, but over the course of time.
So the question then is, do you consider ISQ value of 52 to mean low stability, medium stability, or high stability? And what we're really interested in is seeing if we've influenced you in any way with our first two cases compared to this case. So
let's see what the results are. Here we go.
52 being low stability.
75%.
And the others considering it medium stability. So very interesting results. Yet on the previous case, 50, what was it, 50?
61.
61.
Yep.
So there is some cutoff point between the 50s and 60s then as far as what you're considering medium versus low stability.
One of the things that struck me when I saw the previous slide was that there was a measurement of 20 Newton centimeters for insertion torque. And the reality is I've never seen that in my hands, because when I place implants, I have the insertion torque maxed out, which is usually 45 or 50 newtons. And if the implant, I either know whether the drill stops or it doesn't. And if it stops, it means that I got at least 50. I asked Peter how he did this, and he said, well, he starts at 20, and then if it binds, if the implant binds, then he knows it's at 20. And if it doesn't go in all the way, then he increases the insertion torque, and he may push it up to 30 at that point. If the implant turns a little bit and then it binds, then it's 30. And insertion torque is really hard to calculate. It's hard to measure. You know that you have more than whatever your unit is set at, but you never really know if you have less than that, because typically you'll stop or you'll overseep or strip the implant. So it's really difficult to know what low insertion torques are clinically. ISQ value is very easy, and obviously, as we all know, you can only measure insertion torque once, or you take an implant out of a patient, and you can't do repeated insertion torques because you'll twist those implants.
Well, the other thing when we're talking about the insertion torque, remember you're talking about your handpiece, right? To placing that implant and rotating it at a very slow speed. Well, there are a lot of clinicians that are placing it and they're hand ratcheting, and so obviously depending upon your manufacturer, you have all these different torque wrenches that operate slightly differently, and some have the little thing that bends, and it's giving you, 45, 50, 70, and you can continue to bend it depending upon, how much torque you're generating. But is that accurate? And then again, when we're dealing with implant stability later on, there have been recommendations to use a reverse torque test to see if that implant is stable. I mean, how potentially damaging is that? So, we have to come up with a better way, with a better solution.
Just a show of hands, who has used reverse torque testing in the audience?
Anybody has used reverse torque testing to test the stability of an implant? Come on, be honest. We're not going to name names.
That was the recommended method in the 80s.
Yes.
80s, early 90s.
So
we actually did that.
So an ISQ value of 52 would give me the confidence to submerge it, leave it exposed with a healing abutment, or immediately load this implant.
So this
with
is
an
the value
ISQ
of 52.
Obviously, with low stability measurements, where I don't think any of us would have confidence to immediately load this implant.
Well, for a minute I thought it was 0-0.
Yeah, the majority of you would submerge it, and certainly we will see if
3% actually said immediate load.
no,
Yeah.
leaving it
1%.
exposed with a healing abutment.
Right. So, right, that would be no. That's the C would right. Am I looking correctly? C is immediate load.
Yeah.
It's 3%.
Yeah.
Wow, interesting. So think about it also in terms of implant design, because there also are several articles in the literature that deal with ISQ values in relationship to the design of the implant, and there are differences. So it's not, we're talking about a way of being able to measure not only the stability, but the stability that depends upon the implant design as well. So it really is pretty remarkable that we can get all of this data from one device.
I think that 3% is those aggressive ACT students that I have at UCLA.
Yeah, maybe.
Probably.
Okay. So what did you do, Peter?
I immediately loaded this with a flipper.
Yes.
So we buried it. And as you can see, even though we've reduced the intaglio surface of the removable device, it's still over time compressed into the soft tissue and prevented primary tissue healing, as you can see.
Now, did you? I forgot to ask you before. Did you do any kind of grafting of any kind over the top of this?
I typically place a collar plug after I've grafted the opened areas of the socket, and typically I will see secondary healing with complete coverage of tissue over a period of up to about 3 weeks, 4 weeks. But in this case, because of this patient's grinding habits and incisal wear, he literally seeded that provisional prosthesis into the gingival tissue. So at 3 months, we exposed it and took a second reading. Now it's at 52. So the question is, now what? Refer to Dr. Moy.
This goes back to the question that we asked earlier, and that is, how many measurements do you take? So now we've already Peter's taken 2 measurements.
Yes.
So case number 3.
So allow 6 months healing before taking another measurement. Allow 3 months healing before taking another measurement. Provisionalize and wait 3 months to take another measurement. Proceed with definitive restoration. So with a second value obviously going down, we would be quite foolish, I think, to proceed with the definitive restoration.
Well, does this have anything to do with how fast the patient's paying off the bill?
Yes.
It certainly comes into play
Okay.
as far as decision-making is concerned, but...
Okay, so we have numbers. 81% was for B, allow 3-month healing to take another measurement. So 81%, and then we have 0% for proceed with the definitive restoration,
right.
and 7 and 11% from A to see.
So the majority of you feel that another 3 months would be an improvement.
So what do you think is going to happen during that healing time? You know, being able to have more time, is that going to allow for better integration? And here's what happened.
So there you are. So I agree with everyone in the audience that we waited another 3 months, took a third reading, and now it's up to 71. And this is where we then go ahead and torque the abutment into place to proceed with the definitive restoration. That is not reverse torquing.
I have to say, I probably would have provisionalized that implant at 3 months because we have a positive trajectory on the stability curve. And as I said, I know that loading, as long as it's not excessive, can enhance that osseointegration, enhance the bone-to-implant contact, enhance the maturation of the development of thicker and stronger trabeculae. So at 3 months, whatever woven bone had formed at that point, I think would have been further enhanced, and then you can put this patient into function earlier with the knowledge that the ISQ values are reflecting the physiologic development of the osseointegration around this implant.
Well, it went from 57 to 52.
No, it went up.
Yes.
It went down.
It went down.
Went down.
It went down. It didn't go up.
But
It
Jeff
was-
brings
if
up
it
a
went-
good point.
I'm sorry.
Yeah,
I
no, that's okay.
misinterpreted. If it went up, I would have done provisionalized.
Yeah.
Exactly.
But the other interesting point as well is what we're
57.
went from 57 to 52.
It went down. Then you
Yeah.
wait. I'm
And,
sorry.
and Jeff, actually, there's another question that I was going to ask you related to the early loading phase when Peter was talking about the soft tissue. I mean, certainly part of what we're doing is we're not just having an implant integrate. We're also trying to develop and mature the soft tissue. So in your opinion, when we're doing cases like this, how long do you feel, just from the soft tissue aspect, that we're ready to create a definitive restoration? How long is it for the soft tissue to mature to your comfort level?
Well, there's no single answer to that question, but if you have to go through multiple revisions of the provisional, then it's going to take you several months to get there. On the other hand, if you can get it right the first shot and just let things develop, then you could probably go to definitive restoration in about 6 or 8 weeks. So if you're starting with if you really need to create some papillas and create some nice contours, it's going to take you longer to get to the point where you're happy to finish this. And it could be 3 to 6 months.